Hello everyone, I'll be studying Pediatrics today for NEET PG, and the main purpose of making this video is so that I can concentrate better and study, considering there are only 20 days left for NEET PG. So if you want to join in, you can either watch it with your notebook or your pediatric textbook, and I'll be just reading through it, and in between I might be talking in Kannada also. So please excuse me for that if you're not a Kannadiga and you don't understand that. But that's all. So let's just get started. So starting with neonatology, first the most important ones are Silverman Anderson score. So in Silverman Anderson score, there are 5 categories. In that, 2 are chest retractions, 1 is xiphoid retraction, and the other 2 are the upper respiratory tract. One is nasal flaring, the other one is grunting. So first, the scores are like 0, 1, and 2. 0 is good, 2 is bad. So for 0, everything if it's not there. First, upper chest, lower chest retraction, xiphoid retraction, grunting, nasal flaring, not there. Then in 1, for upper chest retraction, it is lagging. So, and in 2, it is reverse. That is seesaw movements are there, where there is no synchronization between the chest and the abdomen movements. In lower chest retraction, um, it's mild and severe. So for there are 3 categories for which it is mild and severe. So simple, 1 is mild, 2 is severe. Lower chest retraction, xiphoid retraction, nasal flaring. So for the next left is grunting, for which stethoscope, if it can be heard through stethoscope, it is 1, and if it can be heard through bare ears, audible, then it is 2. In this, the scoring is like 0 to 3 is mild, for which you can just give oxygen to the child, and you can give through nasal cannula, mask, or oxygen tube. And if it's 4 to 6, then it is moderate respiratory distress, and that for that you give CPAP. For severe respiratory distress, you give mechanical ventilation. This is Silverman Anderson score, and this is used for preterm babies and to check the mortality. Then next, Downey score. So also as I go, it might get a little slower, and because I'm reading this also as I after a very long time. So please do excuse me for that. So Downey's 0, 1, and 2 again, and here also 0 is good. So how do you remember the 5 categories in this? Arjikar as an Arjikar Medical College. I'm sure you know what it is for. So Arjikar Medical College, R respiratory rate, G for grunting, C for C for cyanosis, not chest retraction. Then A for air entry, R for retraction. So what are the differences here? Respiratory rate is considered, air entry is considered, and cyanosis is considered. And all the retraction is just put into one called retraction. So for 0, which is a good score, respiratory rate should be less than 60. For 1, it is 60 to 80. More than 80 is severe. That is 2. Grunting, again, same as Silverman and stethoscope, 1, 2 here. Sorry. Yeah. If 2 is bad, then you can just hear it with your plain ear. Then air entry, bilateral, normal, decreased, absent. Cyanosis, no cyanosis is 0. Cyanosis at room air is 1. Cyanosis, even with 40% FiO2, is 2. Retraction is, if there is no retraction, it is 0. Mild, severe. That's okay. So Downey is the only thing you have to remember is respiratory rate 60, 60 to 80, more than 80. Air entry, that we know. Then cyanosis. Room air only 1. FiO2 40%, 2. Apgar score is, you'll be seeing it for 1 minute and 5 minutes. And in this, the only compared to others 2 scores, there 0 was considered as good, right? So in Apgar, 0 is bad for the bad score. So APGAR, Apgar, A for appearance, P for pulse, G for grimace, A for activity, and R for respiratory rate. So appearance only. Appearance, if there's cyanosis, either fully cyanosed is bad. So acrocyanosis, that's only the peripheral, I mean, hands and limbs, palms and soles are cyanosed, then it is 1. If it's fully pink and fine, 2 is healthy baby here. There, it was 2 was severe condition. Here, 2 is healthy. So fully pink. So pulse, again, if we go in the reverse order, that is from 210. 2 is heart rate more than 100 is good, less than 101. Pulse, no pulse, bad. Grimace is full grimace, some grimace, no grimace. Activity, full flexion, slight flexion, limp, or no tone is 0. Activity checks tone majorly, and respiratory rate bandu, If there's normal cry, that shows that the respiratory efforts, I mean, are good, not rate. So they might, this can be asked as a question where Apgar score includes all except, and respiratory rate might be put, but respiratory rate is not checked. Only respiratory effort is checked here. And normal cry is good effort. Some effort is there, then it's mild, 1. Apneic baby is 0. So that's about the 3 important scores. And then just the respiratory distress syndrome. So acute respiratory ARDS, that is due to in baby due to decreased surfactant. This we know. I'm just going to go into depths of only those topics that are frequently forgotten or like that are very volatile. So respiratory distress syndrome, for it's usually common in less than 34 weeks. LS ratio, all that's fine. Less than 2 indicates respiratory distress syndrome. So for prevention, what do you give? You give betamethasone and dexamethasone. How do you remember the doses? Betamethasone, beta B equals bara. This is 12 mg into 2 into 24 hours apart. So here B, you can also remember it as 2 doses only. So B is the second letter, 2 doses. So betamethasone 12 mg, 2 doses, 24-hour apart. Dexamethasone, totally, if you're saying, you can realize that beta and dexa total is 24 mg. Here is 12, it's either 12 into 2 or 6 into 4. So dexa is 6 into 4, 6 mg 4 times, 12 hours apart. Then what do you see? You see air bronchogram, black, that whiteout lung appearance on the chest X-ray. Then CPAP, first you give. If it fails or oxygen requirement is more than 40%, then you give Insure, which is intubate, surfactant, and extubate. Insure. So that is main about respiratory distress. Apnea of prematurity, what is it? More than 20 seconds if there's apnea. And where does it happen? It happens in children of less than 34 weeks. So why does this apnea of prematurity happen in children less than 34 weeks? It is due to immaturity of central and peripheral chemoreceptors. Peripheral chemoreceptors. And what do you do here? So you rule out the secondary cause. It could be either sepsis or obstruction, and you give drug of choice is caffeine citrate because it is adenosine inhibitor, so it basically stimulates um, central and peripheral chemoreceptors. Then X-ray is normal in apnea of prematurity. So again, what do you remember? Less than 34 weeks preterm. This also ARDS is also less than 34 weeks. Then late preterm, what is seen as TTNB, which is transient tachypnea of newborn. What where do you see this? It usually happens in late preterm or term, and the risk factor for this is cesarean section because in or infant of diabetic mother. This happens due to lack of ENaC stimulation due to no stress or catecholamine release, which usually happens in the normal delivery. Here in LSAS, this doesn't happen, the stress stimulation. So this leads to more retention of fluid in the lungs and self-resolving in 72 hours. So if child has transient tachypnea, that is respiratory rate is increased in newborn, so you don't do anything for 72 hours, it will resolve on its own. What do you see on chest X-ray? You see fluid in horizontal fissure because all this fluid that's basically been collected, it's not getting squeezed out, and it's the ENaC channels, the expression of ENaC channels is less, and all the excess fluid is not getting drained. Then meconium aspiration syndrome. So what happens in this? Meconium is the first tool that we know, green due to biliverdin, chemical pneumonitis. So because of meconium, if you aspirate it, it can cause chemical pneumonitis, and obstruction of the bronchus by meconium causes collapse. If it's completely if it is completely occluded, it causes collapse of the entire alveoli or bronchus. But if it is partially obstructed, it causes sorry, it causes hyperinflation if it's partial because it gives a ball valve mechanism. Due to ball valve mechanism, partial obstruction causes hyperinflation, and it can, if it bursts, it can cause pneumothorax also. So 10% idre you can give mechanical ventilation, which is high frequency oscillatory ventilation. 10% mechanical ventilation, high frequency oscillatory ventilation is the treatment. Okay, there's no role of intratracheal suctioning of meconium. If they give, that is not the option for it. What is the treatment here? No, X-ray, you can see anything. You can see either black, white out lung, or it could be normal also, or you can see some fluid also. Sorry. You can either see chemical pneumonitis, or you can see collapse, or you can see hyperinflation in this. Then pulmonary alveolar proteinosis. What is this condition? It is autosomal recessive. Autosomal recessive defect is an SPB gene, which is qualitative surfactant deficiency. So the quality of surfactant is not good here. And respiratory distress syndrome in term babies is seen no response to surfactant. White out lungs on X-ray. What is the treatment? Removal of surfactant through lung lavage, and lung transplant is the proper one. Crazy pavement pattern is seen in pulmonary alveolar proteinosis. Surfactant present, pass positive eosinophilic hyaline material. If they mention pass positive eosinophilic hyaline material, it means that it is what is this? Surfactant. Removal of surfactant, lung lavage, autosomal recessive pulmonary alveolar proteinosis. Qualitative surfactant defect. Defect or deficiency? Okay. So other additional fact about respiratory distress syndrome is if gastric aspirate is taken and you put alcohol to it and you use shake test, alcohol test, you can call the shake test, alcohol test, gastric aspirate test, or test tube test, and you shake it well. Then if you see bubbles, if bubbles are present, it shows that there's adequate surfactant. If bubbles are absent, then it shows there is inadequate surfactant for gastric aspirate. Then ARDS, whiteout lung, meconum that we saw. Then congenital diaphragmatic hernia is another condition where most common site is left posterolateral, and the type is called Bocadelic, and cause of death is pulmonary hypoplasia because there's all intestine where will the lungs expand. So there's hypoplasia of the lungs and respiratory distress at birth, and there is scaphoid abdomen because all the abdominal content has gone to the lungs. So there's scaphoid abdomen, respiratory distress at birth, and the main most important thing, bag and mask. Is contraindicated as air from mouth can go into the intestine and it can expand and cause more distress. So, infant of diabetic mother, what do we do about this? I'll do one thing. I'll go to the other. Okay, so infant of from now on, I'll just go on to the important points that will be asked, and the more. If we are at this stage, we know a lot of things already, so I'll be ignoring those things. Okay. Infant of diabetic mother, higher risk of congenital malformation because either due to pre-gestational or gestational diabetes mellitus. In pre-gestational, there is increased risk of congenital malformation. What is this Peterson hypothesis? Where there is hyperglycemia in the mother, so the insulin is secreted by fetus more, and because of that, the baby becomes large for gestational age, and there's macrosomia more than 4 kgs of the baby. I mean, its weight. Birth asphyxia, birth injuries can be common because of large for gestational age. LSCS causes transient tachypnea of newborn because of LSCS. Baby is large, LSCS, transient tachypnea of newborn. Then most common you see is hypoglycemia because there's more insulin. Hypocalcemia is seen, that is more important. Hypoglycemia, hypocalcemia, insulin is decrease it inhibits PTH. So because of that, hypocalcemia either. And hypomagnesemia, glycemia, calcemia, magnesemia, all low. Then RBC, neonatal jaundice, increase in RBC, so it causes polycythemia. And also because there's increased RBC, it can also cause neonatal jaundice because there's increased destruction of RBC also. Then there is increased thrombosis. Why renal vein thrombosis can be there, cerebral sinus thrombosis, priapism also can be seen. Adadmal association. So this is the most important part. Heart, most common is VSD. Most specific for diabetic mother is transposition of great arteries. So common is VSD, but most specific is transposition of great arteries. Then overall, most specific is sacral agenesis or caudal regression syndrome. For heart, this was the most common and most specific, but for diabetic, mother of diabetic, infant of diabetic mother, the most common overall specific is sacral agenesis caudal regression syndrome. Then metabolic hypoglycemia, hypocalcemia, we saw gut, lazy left colon because of neural crest cell migration. Okay, that's all about that. So neonatal hypoglycemia, how do you manage? RBS, if it's less than 40, operational, that's the threshold. So in WHO it says less than 45, but we consider RBS less than 40 as hypoglycemia. Now at risk, what do you do? So who are small for gestational age? Birth weight less than 2 kg, gestational age less than 35 weeks, that's preterm. Low birth weight baby, small for gestational age, then large for gestational age also are at risk for hypoglycemia. Maternal intake of hypoglycemic agents or beta blockers also. Infant of diabetic mother, RH immunization, 6 septic sepsis cases, IV fluids, inborn error of metabolism, that is Beckwith-Wiedemann syndrome allo, there is neonatal hypoglycemia. So in this main ones are those infant of diabetic mother only. But other than that, monitoring uh, symptoms, what do you see? You see tachycardia, tachypnea, sweating. Then if it becomes too bad that the brain, doesn't get it, baby becomes lethargic and seizures can occur. Monitoring you do at 2, 6, 12, 24, 48, and 72 hours. So 2 hours after birth, 6, 12, 6, 6 difference, 6, 12, 24. Then after that, 48 and 72 hours. You do monitoring. Hypoglycemia less than 40, what do you do? First, if it's asymptomatic baby or symptomatic baby, you'll check. So if baby is hypoglycemic or less than 40 mg per DL RBS, asymptomatic baby, but 20 to 40, so mild, that you just give first oral feeds you try. That is breastfeeding. If still it is less than 40, then you give IV fluids. But if it's less than 20, that's very severe. So in less than 20, you directly give off IV fluids. You, even if the baby is asymptomatic, you don't go to, check, try out oral feeds. So in that IV fluids, how much you give? 60 mg per kg per minute glucose infusion. 6 mg per kg per minute, not hour. 6 mg per kg per minute glucose infusion you give. Then, if it's symptomatic baby, then directly you give IV fluids. You don't even consider oral feeds and all, or you don't even check for 20 less than 20. I mean, first you would have checked for less if it's less than 40. So 2 ml per kg of 10% dextrose is given as bolus. 2 ml per kg. That's so for approx 3 kg baby, 6 ml dextrose of 10% dextrose you give bolus. Then 6 mg per kg per minute. That is the same as less than 20 you give. So bolus you give, then maintenance you give on 6 mg. If it's still low, you put increase it to 8 mg. If it's still low, then you slowly increase 10, 12 mg per kg per minute of glucose infusion. So first dextrose bolus, then glucose infusion. Then resistant hypoglycemia, that is glucose infusion rate for resistant hypoglycemia is 12 mg per kg per minute also if you are giving, and if still the baby is hypoglycemic, then you have to give glucagon, you have to give steroids or octreotide or diazoxide. Okay, that's fine. That's not that important, I guess. Then neonatal sepsis is more, if most common in India, according we have to write Klebsiella in NEET PG, but otherwise in INICT they also say Acinetobacter. Then in the world, the most common cause of neonatal sepsis, Bandhu, group B streptococci. Group B streptococci is most common for neonatal sepsis in whole of the world. Then neonatal sepsis, early onset or late onset, you have to divide. Early onset under less than 72 hours. Late onset is more than 72 hours, you're getting infection. Then in risk factors, chorioamnionitis, that is less than 72 hours, makes sense. It comes out chorioamnionitis is there, or premature rupture of membrane is there, or prolonged duration of labor. All these are labor related, spontaneous prematurity, birth asphyxia, or more than 3 PB examination, or yeah. So all labor related. What is the risk factor for late onset is poor nursery environment, all the outside environment, or poor cord care, or bottle or top up feeding, or poor hygiene in general. Okay, this is understandable. Organism clinical features is pneumonia, septicemia, meningitis. So for late onset, the most common one is E. coli. Then diagnosis, how do you know if a baby has neonatal sepsis? You do blood culture. In that, how do you know? Low sensitive, high specific. It has low sensitivity, but highly specific and rarely positive. Okay. So blood culture is gold standard because it is highly specific. Then very high sensitivity is there in sepsis screen, but it has poor specificity. So gold standard for neonatal sepsis is blood culture, but first, what you do, you see sensitivity. So for that, you need sepsis screen. Other you what do you check? 4 components. First is absolute neutrophil count, which has to be less than 1,800 per ml. ANC less than 1,800 per ml. Then CRP more than 1, ESR more than 15, immature to total neutrophil ratio more than 0.2. So only neutrophil is decreasing less than 1,800. Other than that, CRP is increasing, ESR is increasing more than 15, CRP more than 1. or immature to mature, it is more than 0.2. For this, if there are 2 out of 4, then it is considered positive sepsis screen. Treatment and management, supportive IV antibiotics you give, ampicillin plus gentamicin. So what do you give antibiotics for sepsis screen? Ampicillin, gentamicin. Then if meningitis is there, then add cefotaxime, which is third generation for gram-negative to cross-blood-brain barrier. Cefotaxime, ampicillin, gentamicin, cefotaxime. Then lumbar puncture is mandatory in late onset sepsis, regardless of meningeal sign present or not. You have to do lumbar puncture if it's late onset. Then if they have meningitis without meningeal signs, 10% have meningitis without meningeal signs. That's why. Then indication of starting IV antibiotics in late onset sepsis, sign and symptoms of sepsis ಇರಬೇಕು. Plus positive screening ಇರಬೇಕು. So what were the signs again? Clinical features same as septicemia, pneumonia, and meningitis. So signs and symptoms of sepsis plus if there is a positive screen, then you have to start IV antibiotic. For early onset, what do you do? When you already predict that okay, there's going to be sepsis, there should be 3 risk factors or foul smelling liquid, or 2 risk factors plus sepsis screen. So if there is either 3 risk factors or if there are only 2, you should have a positive sepsis screen, or signs and symptoms are there plus positive screening is there also. You have to do whether a risk factor is there or not. Then duration, 3 risk factors. Clinical features, oh, I guess I'm going too much into depth of it. Okay, so 3 risk factors, clinical features. How long do you give this antibiotic for? If there are 3 risk factors but clinical course is incompatible, then you give it for, if there is basically clinical symptoms are not there, sepsis screen also is not there, but risk factors are there. So baby is healthy, the investigations are also normal, but there are risk factors. What do? You give only for 3 days. Then if the clinical features are not there but sepsis screen is positive, that is lab investigation is positive, then you give for 7 days. If symptoms is also there, sepsis screen is also positive, then you give for 14 days. That is pakka. If it's there, both are there, then 14 days. If one is there, 7 days. Then meningitis or lumbar puncture comes out positive, then you have to give for 21 days. 3, 7, 14, 21. 3 if there's only risk factor. 7 if there is 7. If there are what is the sepsis screen positive, then 14 if both are positive, 21 if meningitis. Then necrotizing enterocolitis, acute inflammatory reaction causing ischemic coagulative necrosis of the bowel. Acute inflammatory reaction causing ischemic coagulative necrosis of the bowel. Then most common site is terminal ileum. So terminal ileum and junction of the ileocecal junction. So that is the most common site for necrotizing enterocolitis. Then risk factors and causes. Single most important cause or risk factor is prematurity. That's when you have to suspect NEC. I mean, there's high risk for NEC. Then others include direct or decreased causes. What am I saying? Sorry. One second, I need a little bit of water. So necrotizing enterocolitis is acute inflammatory reaction causing ischemic that we saw. Inflammation basically causing ischemia. Now, what are the risk factors? We saw prematurity. Others, what do they include? One ಏನಾಗುತ್ತೆ directly mucosa is getting injured. Where do you get direct injury to mucosa? One, if there is some drugs that have caused injury to mucosa, like NSAID, or you have given formula milk to the baby, which is causing injury to the mucosa because it's not breast milk. Then, if there is sepsis, or if there is maternal smoking or cooking, it causes direct injury to the mucosa of the child. Terminal ileum and ileocecal junction. Now, where is decreased blood flow present? One, if there is coarctation of aorta, patent ductus arteriosus, absent end-diastolic flow or reduced end-diastolic flow, umbilical artery catheterization. So basically, all blood flow related decrease. That's fine. That we can figure out. Then prevention of NEC, what do? You give breast milk to the baby, you give steroids to the baby because it's an inflammatory condition, probiotics to the baby so that you protect the mucosa. Then clinical features and staging. So this is very important, which is Bell score for NEC, which is if you suspect NEC, confirm. First is you suspect NEC. Two is you confirm AEC. Third is you need surgical NEC. So what are the symptoms? Bell's thing. Okay, 1, 2, and 3. In both, there is 1A, 1B, 2A, 2B, and 3A, 3B. So in 1A, what is there? It's just, there's no radiological signs only in 1A. It's only clinical features. What is the clinical features? Temperature of the baby is unstable. Then there is apnea. Baby is not able to breathe suddenly. Then, or else there is bradycardia. That is temperature, respiratory, and the breathing. All three are affected if you see. Bradycardia, apnea, temperature instability, BAT. What are the abdomen features? Feed intolerance, they're not eating. Or occult blood in stools, that is blood seen in microscopy in 1A. And radiological signs, nothing. So only symptoms and little bit of signs. Then 1B, same symptoms, BAT, bradycardia, apnea, temperature instability. In abdomen, what you see? Here you see gross blood. There you will see microscopic blood. Then radio signs, there is nothing. Again, 1A, no radiological signs. 2A, what happens? You start seeing radiological signs. And here in clinical features, you start seeing other blood related stuff. So in 2A, there is platelet decreasing. And there's pain, erythema, and tenderness. So in radiological signs, you see pneumatosis intestinalis. And then in 2B, you see triad. One now in 2A, platelet decreased. In 2B, there is platelet has decreased, sodium has decreased, and there is metabolic acidosis also. So thrombocytopenia, hyponatremia, that is electrolyte disturbance is there, blood disturbance is there, then metabolic acidosis, acid base disturbance is also there. Now abdomen, what do you see? Same pain, erythema, and tenderness. So it's all becoming like the infection stage. And portal vein gas can be seen. So pneumatosis intestinalis, as soon as they say pneumatosis intestinalis, 2A. As soon as they say portal vein gas, it is 2B. Then 3A is shock and shock leading to DIC. So now the baby is really bad. So what are the abdomen signs? There is peritonitis. Then ascites is seen in radiological signs. So ascites is there. So peritonitis is there. Then 3B is very bad. Now everything, whatever can go wrong has gone wrong. It has perforated and there is air under diaphragm. So that is the last thing. So air encircles lesion, football and abdomen. Okay, it looks like that. So once more. First, there was no clinical signs, BAT for both. Then there was 1A early, there was occult blood, 1B, there was gross blood. Then 2, there was signs now starting. First, platelet. In 1B, there was platelet. Blood, there was something. Blood, what was it? What was it? Blood, bradycardia. No. Blood was there. Acid base balance was something was wrong. Hyponatremia. Yeah. So blood, hyponatremia, decreased platelet, and there was metabolic acidosis. In the clinical signs, what was there? Same, just pain tenderness. Then in radiological signs, there was first one, there was pneumatosis intestinalis, and that's 2A. 2B, there was portal vein gas. Then 3A, everything became bad. 3A was peritonitis and ascites. 3B was perforation, so air under diaphragm. Then management, we saw NPO plus IV antibiotics. Stage 3B, surgery emergency. 3B, obviously, if it's perforation, you have to do surgery only. Until 3A, you can do nilperoral and IV antibiotics. So next topic, neonatal jaundice. So most common okay, before that, we'll just wrap this up. 1 second, just a second. I thought it's going to be a fast session, but I guess it's going pretty slow. But it's okay. Even if we are not wrapping it up, let us do it properly for now. So, neonatal jaundice, what happens? So, most common neonatal morbidity is due to jaundice. It refers to visible jaundice occurs at 5 to 7 mg per dl. You see neonatal jaundice by bilirubin values. Okay, 90% cases it could be physiological jaundice, 10% is pathological jaundice, 60% it affects term, but for preterms, 80% of them get jaundice. So bilirubin metabolism, we know heme, bilirubin, bilirubin, then again heme. So some new drug is no, that's not important. So unconjugated bilirubin is lipid soluble, so it can cross any blood-brain barrier. Plus albumin, it's taken to liver, and in liver is conjugated by enzyme UDP glucuronyl transferase, and it goes to blood, and in bile goes through bile, and two-third forms stercobilin and urobilinogen in stools, and one-third unconjugated bilirubin is reabsorbed back. That's enterohepatic circulation. So bilirubin, then we know this. So why do physiological jaundice occur in newborns? Obviously, lifespan becomes is 90 to 120 days. So versus it's 60. Normally it's 90 to 120, and in newborns it is 60 days. So activity of enzyme UDP-GT is lesser in newborns, reaches adult value only by 3 months. Minor role is increased enterohepatic circulation in newborns. Pathological versus physiological. How do you do? In first 24 hours bandre, it is pathological. In fits to day for physiological. Then more than 2 weeks in term and more than 3 weeks, then it is called pathological. Okay, I'll just read pathological so that we know what is like abnormal. So first 24 hours, more than 2 weeks in term, more than 3 weeks in preterm, and palms and soles. If it's there, it is pathological jaundice. And neonatal cholestasis, that is conjugated hyperbilirubin if it's high. See, if normally unconjugated should be high because there's too much RBC breakdown, so there's unconjugated that's rising. But if there is conjugated hyperbilirubinemia, that naturally indicates it's pathological. Now, bind, that is bilirubin induced neurological dysfunction is there, then it's pathological. More than 5 mg, it is pathological. So I won't be repeating that again. Then physiological jaundice normal pattern is it appears day 2 to day 4 and disappears by day 10 to day 11. So max 2 weeks it will be there, but it has to decrease in 2 weeks. That is physiological. That's okay. So total serum bilirubin 10 to 12 mg per dl is fine. Still, that is physiological, but it never goes more than 15 in physiological. 15 mg doesn't touch in physiological. And it does not increase more than 5 per day also. So that are the two numbers that you have to remember. 15 is the total, more than 5 it doesn't increase per day. Then causes hemolysis, occupy, extravasated blastophyll hematoma, Crigler-Najjar, that is UDP-GT activity is low, that's fine. Then type 1 neonatal cholestasis, type 2 is less than 1% of normal. That is Crigler-Najjar. Type 1 is zero activity. That is, there is neonatal cholestasis, and type 2 is less than 1% of normal. Conjugated hyperbilirubinemia is also known as neonatal cholestasis. Sorry, I did that wrong. I'll just repeat it again. I've just told something wrong now. Crigler-Najjar type 1, there is zero activity. That's all. Type 2, there's less than 1%. Fine. This neonatal cholestasis is next line, which is conjugated hyperbilirubinemia. It's seen in neonatal cholestasis. Then why is pathological jaundice problematic? So, because unconjugated bilirubin can cross blood-brain barrier, it can lead to kernicterus. Acute lethargy, hypotonia, retrocolis, seizures, cry is high-pitched cry, shrill cry, inconsolable cry, baby. So chronic is SNHL. So if kernicterus happens, SNHL can happen. Upward gaze palsy can happen. Dystonia and hypertonias of the body can happen. SNHL, hypertonia, gaze palsy. Then deposition basal ganglia, chorioethetoid valismus tremor. Okay. Why am I reading all this in so much? Okay. Sorry. Then assessment of jaundice, clinical lab. We can use a visual assessment also, which is Kramer's rule. Okay, this is important. Kramer's rule, jaundice in newborn progresses cephalocaudal. One second. Sorry, I should just make my phone away. Anyways, so cephalocaudal 5 to 7 mg per dl superficial jaundice is there only in the face. So face it's 5 to 7. Then if it involves chest, it is 7 to 9. All 2 to 2. 5, 7, 9, 11, 13. So 5 to 7, 7 to 9 is chest. Abdomen plus upper thigh is 9 to 11. Then 11 to 13 is limbs, but not the distal most part. If it's distal most, then it is 15 mg per dl. So five, all 2 to 2, starting from 5 till 15. 5, 7 to 9, 9 to 11, abdomen and thighs 11 to 13, 13 to 15, more than 15. So the transcutaneous bilirubinometer is decreased need for blood sampling by 30%. Then there is okay, so this is superficial jaundice. For deep jaundice, you have to add 2 plus. Then superficial jaundice is lemon yellow, deep orange is deep yellow. Then disadvantages, transcutaneous bilirubinometer is not reliable in the first 24 hours of life. So as soon as you see pathological, you can't just do this. Then unreliable in preterms also, and it's unreliable if child is already on phototherapy. Total serum bilirubin can be checked in this. Then management, first to give phototherapy or double volume exchange transfusion, and no role of sunlight is there in this for jaundice. So phototherapy, what do? You give them blue green light, wavelength 460 to 490. How do you remember? Blue green 460 to 490. How far from the baby should it be? 30 to 45 centimeters should be there. Then types of bilirubin uses LED and CFL. Then irradiance is more than 30. Mechanism of action is structure isomerization. Structural isomerization is a mechanism through which phototherapy acts. That is, unconjugated bilirubin becomes lumirubin, or photoisomerization happens. That is, unconjugated to unconjugated isomer, which is excreted, or photooxidation. So, photooxidation is least important. Contraindication of phototherapy, the most important is porphyria. So, if it's porphyria, you shouldn't give them phototherapy at all because it can cause bronze baby syndrome. If it's sorry, that is if it's conjugated bilirubinemia, it can cause bronze baby syndrome. Then structural isomerization, photoisomerization, photooxidation done. Then side effects, loss of water, temperature instability can happen in phototherapy. So you have to check temperature, you have to check if baby is hydrated. Then damage to retina or gonads can be happening. So you have to cover eyes and you have to cover gonads. Then iatrogenic is bronze baby syndrome, where if baby is given phototherapy in conjugated bilirubinemia, it gets converted into brown color pigments which deposits in skin. Now, double volume exchange transfusion, what do? Normal volume of blood, 80 ml per kg in neonates. Okay, so you pull and push technique. Basically, you're exchanging. Then RH isoimmunization of O negative RBC, AB plasma. Oh, I'm not sure of this. ABO incompatibility. For O, you give AB plasma something. Okay, sorry, I will be leaving this part. I'll check it out and tell later. Side effects is potassium should double volume exchange transport. What can happen? Potassium can increase, calcium can decrease. Potassium increases, calcium decreases. Volume overload can happen, and infection risk is there. So pull and push technique we should know. Basically, they're exchanging the blood volume itself. 80 ml per kg in neonates. Normal volume. 80 ml. So 80 into 3 is so 240 ml blood. So management algorithm, do visual assessment every 6 to 8 hours. You come and you check the baby. Then serious or significant jaundice. How will you know? Serious jaundice is first in 24 hours only. It has come, involves pumps and spines. Start phototherapy and send to check the serum bilirubin very frequently. Then if phototherapy cutoff is more, then continue phototherapy. If it's more than this phototherapy cutoff, you start for double volume exchange transfer. That false alarm, if it's just like the bilirubin is less, then you just stop phototherapy. That is if in serious jaundice. Significant jaundice, unsure about visual analysis, send for value. This is just very obvious. Then After that, birth asphyxia. Okay, this is important. Birth asphyxia, how does WHO define it? Inability to breathe at birth. And if moderate, if it is Apgar score is less than 7 at 1 minute, or severe is when Apgar score is less than 4. So 7 is moderate, 4 Apgar is, should we, what were the call it, 0 was good enough Apgar, right? Yes. Bad. 0 was bad enough Apgar, sorry. Then ARP criteria for severe birth asphyxia, all criteria. ARP is American Association of Pediatrics criteria for birth asphyxia. All criteria should be present in this. One, umbilical cord blood should be less than 7 pH. Then Apgar score should be 0 to 3 in 5 minutes. So less, PHL acidosis is there, less than 700. There is acidosis in blood, umbilical cord. Then I mean, you can see through umbilical cord blood. Then 0 to 3 is at 5 minutes, Apgar score at 5 minutes is 0 to 3. Or there is neurological dysfunction. How do you know it? Through seizures. Or one, one other organ involvement is there. Most common is acute kidney injury. So neuropathology is, what do you see in terms and preterms? In terms, you see parasagittal infarct. In preterm, you see periventricular. So parasagittal in term, periventricular in preterm. Then, in because this parasagittal infarct, you see spastic quadriplegia in term. In preterm, you see only diplegia, but it's again spastic only. And necrosis, cortex and hippocampus can get necrosed in term. And in preterm, it's subcortex and pons and midbrain. Okay. Diplegia. So it's actually lesser in preterm because periventricular area and subcortex, pons, and midbrain is involved. Hypoxic ischemic encephalopathy. Birth asphyxia leads to HIE. Yes. Then what is the most important in this? Sarnat and Sarnat staging, in which 1, 2, and 3. So 1 is relatively okay, 2 is fine. I mean, 2 is worse than 1 and 3 is the worst. So 3 is the most severe one in Sarnat and Sarnat staging. That is stages. What and all do you check? Consciousness. If baby is irritable, it's still fine. But if the baby is lethargic, that's bad. And coma to is the worst, severe. So irritable, lethargic, coma. Then reflexes, if it's exaggerated, it's still fine. If it's depressed, it's bad. So a crying baby is better than a baby that's not crying here. So exaggerated reflexes are still better. Depressed is bad. Absent is worse. Seizure is if there is present only in the second one. So as soon as this is seizure, you see Sarnat and Sarnat staging 2. Then autonomic involvement, sympathetic is 1, 2 is parasympathetic, and no activity in 3. Pupil mydriasis, that is again all hyperexcitation stages in 1. So mydriasis there in 1. Then heart rate is also increased in 1. Posture is also normal. EEG is also normal. Prognosis, 99% of them are fine. But in 2, everything is depressed. So baby is lethargic, reflexes are depressed, but seizures, that is the only hyper excitable kind of thing that is seen in 2. Then parasympathetic overactivity is there, meiosis is there, all like, the calming effect of it. And then heart rate is decreased, abnormal flexion and decorticate position is 2. Low voltage complexes are also seen in 2, and prognosis is 80% normal. Then third one is consciousness, if if the baby is in coma, or reflexes are absent completely, or autonomic involvement, there's no activity at all. Pupil size is variable here. Heart rate is also variable here. Abnormal extension or decerebrate posture. So decorticate is 2, decerebrate is 3. Then low with burst suppression is EEG. Then 50% die, 50% abnormal. Imaging is term MRI. Term pretermally USG brain, ultrasound brain. Term you do MRI. So if the baby is preterm, you take them for ultrasound. This is HIE, which is again birth asphyxia. What was the criteria again? The 4 criteria according to American Association: less than 7. Then should be Apgar score less than 0 to 3 in 5 minutes. Seizures or neurological dysfunction or any organ involvement. These are all the criteria. Other than that, for WHO, what was it? More inability to breathe at birth. Spastic quadriplegia term, spastic diplegia preterm. Okay, management now. How do you do it? Mostly supportive in nature, admit in NICU, give O2, give anti-epileptic, maintain normal metabolic state. Specific management modality is therapeutic hypothermia. You maintain therapeutic hypothermia. Where do you see? You see in do it in HI. Then mechanism is when you decrease temperature, there's decreased neuroinflammation also. Criteria is gestational age more than 35 weeks, time immediately within 6 hours. HI stage 2 or 3. If gestational age is more than 35 or time immediately within 6 hours or HI stage 2 and 3, birth weight more than 2 kg, you can do this therapeutic hypothermia. 2, 3 more than 2 kg baby immediately within 6 hours. You have seen this or started this or gestation age more than 35 weeks. Neonatal seizures, most common cause is HIE. Most common type is stage 2, where it is subtle. Best prognosis is focal clonic, worst prognosis is myoclonic. Then do temperature ABC, that airway breathing circulation. If you give phenobarbital, phenytoin if refractory, give first you give phenobarbital in children's seizures. So newborn seizures, first drug you give is phenobarbital. Then if it's not working, you give phenytoin. Or if it's refractory, you give vitamin B6. Primitive reflexes. Okay, this is very important. Again, the most rooting reflex. So 28 weeks of period of gestation. In some places they do say 32 weeks. 28 weeks only it comes. It will stay for 1 month. Rooting reflexes when they that only. Yeah, when they move the scratch on the side of the lips, the baby turns towards that side. Right? Yeah. Moro's reflex is 28 to 37 weeks. It stays for 5 to 6 months where there is that hyperextension when you drop the baby like this. And Palmar is 28 weeks. So everything is almost 28 weeks only except atonic neck reflex, asymmetric tonic reflex, that is 35 weeks. So 28 weeks bandu, it will disappear in one. Rooting reflex 28 weeks disappears in 1 month. Moros reflex comes again at 28 to 37. So till term also it can come. Then it disappears in 5 to 6 months. 5 to 6 months it stops doing this. 5 to 6 months. So until it's breastfed, by the time you stop breastfeeding, it'll stop doing this. I don't know how that's going to help, but Palmar grass, 28 weeks, it starts. Again, 3 months, it will stop holding the palm, grasping onto people's hands. 3 months, it stops. Then atonic neck reflex is in Guy, it is 3 to 4. In Nelson, it is 5 to 6. So 3 to 4 or 5 to 6. And when does it start? At 35. Rest all almost 28-ish. Only atonic neck reflex is at 35. Then after birth reflexes are symmetric tonic reflex. That was asymmetric tonic. Now symmetric. This starts only at 6 to 8 months of life. So by the time Moro stops, this symmetric tonic neck reflex comes, and 10 months it disappears. So it's there only for almost 2 months. 6 to 8, 10 to 12, it disappears. Parachute is 8 to 10 months, and it will be there throughout life. So first symmetric tonic 6 to 8, then neck parachute is 8 to 10, then Lando Supernova. Okay, I don't know what that is. Rooting reflex, first reflex to disappear, mouth wide open and head turns to the stimuli. Moro reflex, also known as starter reflex, appears 28 to 37, 1 days of 5 to 6 months. Opening, extension, abduction. Extension and abduction. So flexion, extension, abduction, then flexion and adduction of upper head, of head and trunk, and then crying. So first is OEA, opening, extension, abduction, then flexion, adduction, then crying. Then absent Moro is there in this Downs. So Downs you don't see Moros. HIE stage 3 you don't see Moros. Kernicterus you don't see. Asymmetric you see in Erb's palsy or clavicular fracture. One side is affected. Then abnormal persistence is there in cerebral palsy. So in cerebral palsy there's no absent. You say it's persistent. Moro is there throughout because they're immature neurological functions. Hand regard disappears by 5 months. Okay. Exaggerated Moro is in hypoglycemia because there's sympathetic stimulation there, and HIE stage 1 again because of sympathetic overactivity. The asymmetric tonic neck reflex is the Hanuman posture where you turn the neck towards one side, that the limb extends and the opposite limb flexes. Wherever you turn, you extend that. Then fencing reflex 35 weeks, or it's also called fencing reflex 35 weeks, and it's there till 6 months. Then turning to one side flexion, okay, this I told. Then breast milk and breastfeeding. So in breast milk reflexes, milk ejection reflex, galactokinesis is milk ejection reflex, that is through oxytocin. Now, milk secretion is through galactopoiesis, which is P for P, prolactin. So, galactopoiesis is milk secretion. Now, good posture, baby facing mother, head and neck, this was fine. Mouth wide open, areola, lips ever completely inside the mouth, or if only the one top part is exposed is fine. Lips should be everted, chin should touch the breast, that is fine. Now, more breast milk versus cow milk comparison. In breast milk, there is more lactose than cows. That is 7. In fat, in fat is almost equal in both breast and cows. Now, DHA or arachidonic is more in breast milk. That's why it's good for the brain. Then calories 67, more in breast milk. Breast milk has more lactose also, more calories also compared to cows. Protein, but is more in cow's milk. So, other than that, whey or casein, whey is to casein. Whey is absorbed and coagulates and not absorbed. Which one is absorbed? Whey. So whey is absorbed protein. Casein coagulates and it's not absorbed. So whey should be more in an ideal, milk. So in breast milk, whey protein is more. So 70 is to 30. And in cow's milk, casein is more. So 20 is to 80, which is most of the good proteins not absorbed well. Then calcium phosphate ratio 2 is to 1, which is better absorption. Calcium better absorption is there in breast milk, and 1.5 is to 1 is cow's milk. So base better, calcium phosphate 2 is to 1, better absorption. Then protective factors. So for lysozyme it has, which is effective against gram positive. Bifidus is effective against gram negative. Lactoferrin against gram negative. E. coli, Shigella, Salmonella is for bifidus. E. coli, Shigella, Salmonella, and that's for lactoferrin. That's lactoferrin against those. Anti-staph is there. PABA is there against Plasmodium. Bile stimulated lipase is there against Giardias. So lysozyme gram positive. Bifidus gram negative. Lactoferrin again gram negative. Bifidus lactoferrin against gram negative. Staph is against staph obviously. PABA is against Plasmodium. Bile stimulated lipase against Giardia. Then there is advantage of breast milk. NEC ಕಡಿಮೆ ಆಗುತ್ತೆ, sepsis ಕಡಿಮೆ ಆಗುತ್ತೆ. That is, it decreases risk of NEC, sepsis, hypocalcemia, hypoglycemia. And in older kids, it decreases allergy, type 2 DM, increases IQ, and decreases evening colic. Room temperature storage is 4 to 6 hours. You can store breast milk in room temperature, 4 to 6 hours. If it is refrigerated, you can store it till 1 day, 24 hours. If it's in freezer, you can store it for 3 months. So breast milk, room temperature 4 to 6 hours, refrigerated 24 hours. Okay, it's fine. I'm feeling tired telling it out loud. But at least I'm finishing it, so. Then types of milk: colostrum, transitional. Types of milk is colostrum, which comes for 2 weeks or 3 to 4 days minimum. Then transitional is after 3 to 4 days until 2 weeks. Fat and sugar is high in this in transitional. Then mature breast milk comes after 4 weeks only. So in colostrum, there's increased IgA, increased proteins, and decreased fat. So it is thicker. So there is more protein, so it's thick. Then in later on mature milk, there's more fatty acid and less protein, so it's thinner. So here it's a little opposite. Less fat is thick. Then fore milk quenches thirst, in milk nutrition for appetite, that we know. Contraindications, absolute contraindication of breastfeeding is galactosemia, or mother is on chemotherapy. Relative is active HIV, active TB, active herpes. All noted point is that it should be active. Not a contraindication. This is very important. Lactational mastitis is not an infection. I mean, not a contraindication. Maternal smoking or drinking is not a contraindication. Breast milk jaundice is also not contraindicated. Active hepatitis B. Hep B, if it's active also, it's not. Some other random points. Breastfeeding jaundice is seen in first week 24 to 48 hours after birth. Because of dehydration, you see breastfeeding jaundice. But breast milk jaundice is seen in after seventh day. That is after late barodu breast milk jaundice. That is 2 to 3 weeks. 7 days to 2 to 3 weeks. That is due to beta glucuronidase deconjugates, and this if persistently high, you can give formula for 24 to 48 hours. So intestinal bilirubin is increased in breast milk jaundice. Deconjugates intestinal bilirubin. So breastfeeding jaundice is the first one. That is dehydration. Then anterior fontanelle closes at 18 months. Posterior fontanelle 6 to 8 weeks. Third fontanelle is present in trisomy 21. White pupillary reflex or leukocoria seen in congenital cataract, chorioretinitis, retinoblastoma, retinopathy of prematurity, and persistent hypoplastic primary PHPB. Um, what else? DHA and ARA, arachidonic and docohexanoic, important for growth. Okay, that's some miscellaneous points. So the starting part of neonatology is little. I didn't cover that. I'll cover those two. Neonatal resuscitation I won't be doing because there's some date in that. Ponderal index less than 2 is asymmetric IUGR. Less than 2 is still fine, asymmetric, where the head size is preserved. So it is brain development is fine, only the limbs are smaller, the body is smaller. So ponderal index formula is birth weight in grams divided by length cube into 100. Just okay. Cephal hematoma maximum size at day 7 and resolves by day 21. So it almost takes 3 weeks to resolve. Caput succedaneum is day 1 only, it's there and it resolves in 1 week. So it's not that serious. Then vitals of newborn: temperature 36.5 to 37.5, heart rate 100 to 160, respiratory rate 40 to 60, BP 60 by 40, CFT is less than 3 seconds. Passes urine by 24 hours according to Guy, and meconium by 48 hours according to Guy. But in Nelson it doubles. Erythema toxicum neonatorum has sterile eosinophil pustule. Post-term is considered after 42 weeks. In preterm, it's late preterm is 34 to 36 points, 36 plus 6. Middle preterm is 32 to 33 plus 6. Oh, sorry, I guess I'm filling it wrong. Low birth weight is less than 2.5 kg is low birth weight. Very low birth weight is 1.5, so the difference is 1. And extremely low birth weight is less than 1 kg. That is there. It's not even 1000 grams. So most of it is neonatal resuscitation. Hypothermia in child is temperature less than 36.5 measured at axilla by digital thermometer. So 36 to 36.5, that's 0.5 difference from 30. The normal is considered mild. Very severe is less than 32. So anything in between is moderate. 32 is severe. And then prolonged clinical features is acrocyanosis, cold extremities, irritability. Late features of hypothermia is if its baby is lethargic, not feeding, bradycardia. Prolonged is hypoglycemia, sepsis, and AKI can happen. So the temperature, hypoglycemia, temperature instability can happen due to temperature instability. Sepsis can happen. They are mostly a fire. Then what do you do for severe hypothermia? You check RBS first. That is, if it's less than 40, you have to give bolus, the normal hypoglycemia treatment you have to do. Then in term, you have to give IV fluids 60 ml per kg per day. Then in preterm, you have to give 80 ml. Then give oxygen. You give because there is risk of in hypothermia. There's risk of sepsis also and bradycardia. So you give oxygen injection, vitamin K in case of DIC, rapid rewarming till to 34 degrees Celsius. Vitamin K is given, oxygen is given, hypothermia, rewarming is done. RBS you have to check. Incubator source of heat is through convection, but radiant warmer it's through radiation, and the loss is through opposite. Kangaroo mother care we know. For who do you do it for? Stable low birth weight preterm babies who are stable you can do. Skin to skin contact decreases hypothermia, decreases hypoglycemia, decreases sepsis, decreases mortality. When do you stop giving kangaroo mother care? When the low birth weight baby till it reaches 2.5 kg you can give, or if it's a preterm baby till it reaches 40 weeks of post menstrual age you can give 40 weeks. Then gut motility for less than 28 weeks, there is no gut motility at all. So you give IV fluids and parenteral fluids. If it's 28 to 31 plus 6, that's almost 32 weeks, then they have gut motility, but they don't have coordination. So you give them a nasogastric or oral feeds. If 38 to 34, then you give Katori spoon pallidi feeding. If it's more than 34 weeks, you can breastfeed the baby. So 32 to 34 pallidi, 28 to 32 NG tube, and less than 28 IV fluids. Then nutrition supplements more than 2.5 kg, you give oral vitamin D of 400 international unit per day. So normal baby you give 400 international unit per day of vitamin D for 1 year. You have to give this vitamin D dose. 1.5 to 2.5, that is low birth weight baby. You give vitamin D double, that is 800 international unit per day. Iron also you give 2 to 3 mg per kg per day. For 2 years you have to give. If baby is low birth weight, then you are giving supplement for how long? 2 years you have to give supplement. If baby is less than 1.5, you give vitamin D, iron, and you also give human milk fortifier, which is still 2.5 kg of weight. That's it about neonatology, and we have completed a big chunk of it. For neonatal resuscitation, I guess I can just do one part of it through notes.